Well, good morning. It's a really great pleasure to be back home. Chris and Kimbra, thank you so much for all your organising. Johnny and Janine, thank you very much as well. It's great to be back among friends, people I've trained with over many years. As Johnny said, I have been a bit of a journey, but you never forget your roots. And it's interesting that in 20 years in Boston, 12 months in Toronto, people know I'm an Aussie. They give me some leeway as a result of that. But it's very important to me personally that you never forget your roots. I'm so grateful for the people that trained me and inspired me, and for the people that I continue to collaborate with. So the talk this morning about can technology make us safer has been a focus for many of us for some time, and it comes from a lot of external pressure on us as a field to make us safer. The IOM report of over 10 years ago, where there was 100,000 lives that were or could be saved through improved safety, has now been upgraded in the last 12 months to 180,000 lives a year. So despite over a decade of this initiative to really enhance safety, it seems to, at least the reports that we receive, we're not doing a very good job. One of the areas that gets very little attention is the most intense area of medicine, the critical care environment. It's the most resource intense, it's the most costly, and it's where most of the deaths occur, particularly in pediatrics. So what I wanted to go through here is really a journey and show you how technology can in fact make us safer, although we're not there yet. I might use this one. I do have a disclosure that I will be talking about T3, which is a tracking trajectory trigger tool, which I've been the lead developer. But let me start by just really highlighting one of the key points, and that is that we work at the interface between human factors and technology. And the human factors component to the way in which we manage patients in critical care is really quite unique in our environment. I'm not going to dismiss it. I will talk about it a little, but it's not the focus of this particular talk. It's how technology can enhance the management and the safety of our patients. Now, technology clearly can improve the quality of care. We see new equipment, new devices, new strategies for management, new drugs, a whole lot of aspects that are coming into our environments all the time that inform our decisions, they lead to innovation. But I'm not going to talk about quality of care, because I think we deliver outstanding quality of care across the field. There's no doubt that technology enhances our processes of care, our workflow, and our environments. The new eras of critical care development and the types of environments that are now being developed are wonderful. Although I must say that they also bring unintended consequences related to scale and visibility and workflow that we need to consider as well. But I'm not going to concentrate at all on the environment of critical care. And I will talk about safety, because technology will enhance our safety. But we need to understand the complexities, the unintended consequences related to this complexity, the distractions that occur, and our varied interpretation and responses of the data that's before us. And this is a fairly typical environment. We look at this and we can understand it. All of us have experienced it. It doesn't faze us, but there's a whole lot of information that's coming into us about that patient in the center of this slide that we have to integrate. Nothing's integrating it for us. I've had pilots and other people in high-risk industries look at this environment and they can't take it in. The same as when we sit in a cockpit, we can't take all of that in as well. It's context specific. So the environment of ours is increasing in complexity and intensity, and it's changing as well, particularly in the ICU environment that in many respects has become an operating room. We do a lot of procedures, open procedures in the ICUs now, so that adds yet another layer of complexity and safety that we have to be familiar with. So can technology improve safety? Well, this is the report that's generated every month at Sick Kids that goes to the executive and then to the Ministry of Health. This is our scorecard for quality and safety. And there are a number of metrics there that come up from the intensive care unit. And we're held accountable to this. We have stretch marks, targets, and stretch marks probably. But it's hard to glean anything from this, and at the coalface, so those of us working at the bedside, this is often meaningless as a way in which for us to improve safety. And these are the metrics that we currently use to prevent harm, improve safety. The hospital wants to see these every month: healthcare-acquired infection, inadvertent extubation, readmission rate, med reconciliation, transfers and discharges from the ICU, medication safety, specimen integrity, and pressure care. These are how we are measured in terms of delivering safe care. And of course, there are bundles and all sorts of processes that we apply around those. But what we don't measure very well is the performance, our performance, and how that impacts on safety. One metric is preventable or possibly preventable cardiac arrests, and that's a metric that I used in Boston. We're using in sick kids as well, to really look at the way in which we perform as a team and perhaps make some decisions. But we really don't have metrics that tell us how we utilize our resources and organize our workflow. We don't measure practice variability, although it is extreme, both within and between institutions. Adherence to policies and procedures is an emerging metric, although I think relatively meaningless. And then we don't capture perhaps the most important, which is the decisions we make. Technology can help us in these regards. Now, I did mention the human factor component. You cannot ignore that, and it's a very important component to patient safety. And each of those metrics that I talked to you about that we get measured upon have these various components that really we try to address to reduce our risks, or the patient's risks, I should say. So we have various processes of care for all of those particular metrics. We have some rules we have in place. We look at workflow and distractions. We have a read aloud process for specimen integrity, for medication delivery. We look at our workflow. That's looking at the systems of care that we provide. But you can't prevent everything. This is a little guy not so long ago in the ICU. I was called to the bedside because and when I turned up, you can see that he's got a mask over his face, and in his left hand he's holding the endotracheal tube. He'd been nasally intubated for his surgery, and he decided it was time to, just to highlight this here, he decided it was time that he was extubated. I don't think technology could have prevented that. That's a system of care that we needed to have in place. But it is a tough environment. This is a study by Chris Parsheram at Sick Kids. It's back in 2008, and it's possibly a little bit outdated now, 5 years down the track. But what he pointed out was that there are these are actionable decisions, and not decisions, but data points in the electronic health record on a patient on a daily basis. And the mean was around 1,400 data points a day that we have available to us. And that depending on the complexity of care, that number increases. Obviously, patients with ECMO seem to have a much larger number of data points. So we have a lot of information and data points that we have to integrate on a regular basis. And then we throw into that a workflow that is becoming increasingly distraction, in that we have computers on wheels, we have phones that incessantly go off and that people will answer at any point, because that takes precedence over anything you may be saying at the bedside. We pull people away from the bedside all the time. The workflow is becoming harder and harder for us. And the problem with that is that events occur, we have harm to the patient, and then we go through it in a sequential way. We look at in a chain of events, and almost always we come up with there's a human error. One of us made a mistake. The problem with that type of analysis is that it always drifts us back towards risk. We put a process in place to try and prevent what occurred, a new policy, a new way in which to approach that particular problem. It's difficult to sustain, and then some point later, the same event occurs. Because we have really focused a lot in critical care on the concept of failure to rescue. And in fact, we all have very low failure to rescue rates. Patients in our units who have critical illness, critical events, we recover them really well. We have great safety nets in place. But safety nets are not always what they seem to be. Patients still get harmed despite those safety nets. And what we need to be is looking at the front end of this. That's how predictable are the events that are about to occur. And you need to look at all the dynamic controls in the intensive care unit and the entire system. And it's not just the technical and procedural aspect, but the social dynamics within the ICU as well. Recognizing that it's non-linear, that we have parallel processes running all the time, and that human error is usually the symptom and not the cause of the event. Because I think the most important thing we need to do in critical care is to prevent events. It's our failure to predict that should be our metric. So if we look at technology in our ability to predict an event, there are a number of aspects that I think are emerging and will help us. Let's take healthcare acquired infection. We all have benchmarks available through the electronic health record, through other data systems. But more importantly, the aspects of the signal variability, the frequency of signal variability is actually becoming more and more an interest to try and predict the likelihood of a patient developing an infection. So this is respiratory rate variability, heart rate variability. Same for failed extubation. Respiratory rate variability is a potential there. So that's looking at the frequency and the change in frequency of the signal of your respiratory rate and patient's own respiratory effort. Medication safety. Well, it's a requirement that there be computer order entry. We've introduced smart pumps, or as I like to call them, the not-so-smart pumps, and barcoding. This does not eliminate medication errors. As long as you have a human that's at some point within that interface, there will be the potential for an error. Specimen integrity, we're trying barcoding to try and make sure that we get the right specimens and the right patient to the lab. Readmission, much harder, but we have an automated electronic early warning scoring system that may be able to help in that regard. Things like preventable cardiac arrest, risk estimation and probability assessment, so looking at the signal and integration of those signals is another way in which we can use technology. All of these rely on us capturing data, and using that data wisely, and transforming that data into information. That's not done in intensive care. We need to do it, and I think we're on the cusp of being able to do that in a very scalable way. Because technology will only enhance safety by transforming data into real-time, meaningful information. The data in and of itself doesn't help us. It's got to be transformed to information for us at the bedside. And what we need to do is to forecast. We need to utilize this, to use the term that's very commonly used these days, big data, and transform that, as I've said. The risk management component of intensive care is really very important to us. And that's really what our job is. We are risk managers. We are all the time evaluating the benefit of the intervention as opposed to the risk of it. And we need to be able to look at what is the modifiable risk. There have been, if you look at critical care studies, where the risk for critical care is often comes down to, well, what's the length of stay, mortality obviously, but let's step away from that. Let's look at other metrics like the length of stay, the duration of mechanical ventilation. It's pretty hard to modify that. You need to go to the step before that, which is what are the modifiable things that we do, the decisions we make that can really improve that risk-benefit ratio. We need to be risk-tolerant, not risk-averse. But we need to understand what our contribution is at the bedside in the decision-making that affects outcomes, and technology can help us in this regard. Recently, the IOM published a summary paper on making the case for continuous learning from routinely collected data. Interesting, makes a lot of sense. The routinely collected data, though, doesn't apply to intensive care environments. It refers to the information that's in the electronic health record that is collected across on a whole enterprise-wide platform that is really static data. They're isolated points of data. And the problem for intensive care, where we have this wealth of continuous physiologic data streams, is that we can't currently capture or visualize that data very well at all. That data flies across your screen at the bed, and it's gone. Now, you can store it for 96 hours in some systems, and then it's gone. But that storage of that data is very difficult for us to access, and it's in fact not in a form that allows us to use it. The data that we would like to be able to visualize and capture is very vendor specific. There's very limited integration between any device. So therefore the data streams are fragmented, they're isolated. We can't store them, therefore we can't access them to use them. We can't share the data, and that would be the goal. There's no reason why I shouldn't be sharing data from my ICU with the ICUs here. It can be done very easily, and we should all be able to learn from each other. Now, I've been involved over the last 6 years with an organization called Risky Business, which is really designed to, you look at other high-risk industries and how they've adapted their processes of care and how we might learn from that in healthcare. Formula One racing was Alan Goldman in the UK, in fact, started to look at this process from the aspect of team training. And you can see all these patients, all these, the crew around this the Ferrari team here, and just the synchronization of all of this to change the tires, fill the car within 12, 14 seconds. It's phenomenal. A lot to learn from them. There's about 14,000 parts in that car. Half of those parts are monitored continuously with data fed back to trackside computers as well as to remote computers back at the base for various organizations. And there's a panel of people that sit there and they're watching all this information and they're getting high fidelity, high frequency information all the time, and they're looking for the pattern recognition within that and deciding what needs to change on that car, where the problems are emerging. That's standard for Formula One. It's not standard in healthcare. Then you take NASCAR in the United States. Very interesting as well, in that they have a different approach. So for 3 days before a NASCAR race, the drivers and the crew work on their car. They take it out, they do an hour of testing, and they're coming back in and out to their garage every time they go do a few laps. They're collecting the same amount of data, really, that the Formula One cars are collecting, and they're working on that information real time to adjust that car. And they do that for 3 days. And then on race day, they turn all of that off. They've had 3 days to prepare the car, understand it, and then on race day, it's the driver and the car. And they don't use any data during the race. I don't think that's a model that we would necessarily want to ascribe to, but it's really the human and the car that really determines what the outcome. So there are different ways, obviously, to approach data and high-frequency data. And the similarities with healthcare is that these are very complex systems. They are highly regulated and governed, as we are, and it is this interface between human factors and technology. Now, this was a brochure I discovered when I started at Sick Kids. This is in 1993 when the Sick Kids Atrium building opened. At the time, a wonderful building, still is a wonderful building. But notice here it was described as the hospital of the future. And the reason it was described that is that this is John Edmonds, John Tate, working in the intensive care unit and with the early versions of the Mac computer. And they developed a system that enabled you to, within the ICU, to look at information regarding the ventilator. They had a flow sheet integrating and pulling in lots of information from the bedside. And they even had an order entry system. They were ahead of their time. They were the first people that did this. Why wasn't it sustained? Well, you can see here, this is one of the nurses, Rose, who still works in the ICU. She's got the computer screen in front of her here with the patient flow sheet and information being presented to her. But that was just not sustainable, and there are a number of reasons why that was the case. Primarily, this was a visualization tool, and there's a limitation to those. We couldn't store data or analyze it at that point. This was too early on in the whole process in terms of being able to capture large amounts of data. It was expensive, and IT was rapidly changing. It was very ICU-centric, so it wasn't scalable across an institution. And then two other things occurred. One was that there was this rapid growth in monitoring systems that became more and more vendor-specific, so you couldn't actually pull the data from them to incorporate into a system that John developed, and that there was this electronic health record on the horizon that's going to save the day, it's going to make us all better. So it fell away in the mid-1990s, which was a huge, huge loss. And we're now trying to catch up to what they started. If you look at ICU and big data, we have a huge variety of data, which makes it hard to implement clinical protocols. We have a large volume of data that is, as I said, rarely stored, and we have a large amount of velocity of data. So it's coming at us in a huge amount with high frequency. And it makes it hard to us to integrate and anticipate events, and yet we need to, because that's where the ICU is where the highest mortality rate is, and it's where the highest costs for healthcare are in academic institutions. So what's our journey? Well, the journey in the ICU for me starts with looking at the front end and the back end, and this is the way we currently practice. So on admission, we know the diagnosis, the procedure that patients have had. We risk adjust it based on various benchmarks and acuity indices, PIM, PRISM, whatever you use. And then we use that to look at, well, what's the discharge going to be? We look at the back end of this, and we know what our outcome should be, how we're going to benchmark it, what the expected mortality, potential morbidity is. What we don't know and should know eventually is what's the quality of life that our patients are going to have after they've received our treatment. But that's how we currently practice. And then we overlay that with a whole lot of guidelines and protocols and metrics and early warning systems to try and improve the care we provide. Then we attach them to various monitoring devices. We collect everything in the electronic health record, and we think we've got this patient covered. And then we do this. These are all nodes of decision making, and we bounce all over the place. People interpret this data differently, and practices vary as a result. So we end up having this variability in practice that is very costly, but also leads to error. And that's a target that we have to really go for and understand. Well, the monitoring systems, this is the current setup here where we have all sorts of monitors, from the pumps, the ventilator monitors of any sort, that go to their own specific gateway that may feed across into the hospital network, and data points are pulled out from that to populate the electronic health record at defined points of time. So it's pretty static information. What we want is to be able to take this information, put it into the single gateway. It all comes into one area, and with the various drivers and the programs written for various drivers that allow us to then populate that EMR, but more so to actually capture that information. And it needs to be scalable, it needs to be enterprise-wide, and vendor agnostic. There's a whole new industry that's developing around this. That is, because these various companies that make the monitors, the pumps, the ventilators, they're not going to do that. It's not in their interest to do that. They're hardware companies. There's a new group of software companies that are emerging that are writing drivers specifically for these devices so that we can capture that information continuously in real time. The electronic health record, it's been quite a journey, and I have some fairly definite views as to the value of the electronic health record within critical care. It's obviously an important repository of information. Order entry, I think, is very important. Clear order sets with limits that are also established. It's enterprise-wide, but there are limitations. It's periodic information. The performance of electronic health records are not designed for what we do in critical care, and it's very hard to pull the data out for us to use it real time as well. In 2008, we went live in the critical care units, and Elaine will remember this very well, with the Cerner system. the system had been implemented at Children's Hospital 2 or 3 years beforehand in ambulatory and inpatient areas, but not in the ICU. We worked at it, we wrote all the flow sheets, we thought we were ready, went live with it, and 2 weeks later, I took it out because we had definite patient harm as a result. More so, I don't think I've ever seen a nursing staff more distressed at the bedside than they were over this 2-week period, because if you look at your workflow at the bedside, pulling information from so many sources and having to work in parallel, this sequential system could not keep up with what we had to do. It did not match our workflow. So we actually removed it because it was so unsafe, and then reintroduced it about 18 months later in a very gradual fashion, and it's now in place. It's in place in a different system at sick kids as well. But you have to understand their limitations and work within them, but it does impact us. There were 2 things that came out from a review of why we took the Cerner system out from the ICUs. The company called us out to Kansas City. We had a big sit down. We went for an entire morning talking about all the problems. And in the end, I said, well, this is not getting us to the answers here, because it still doesn't fit our needs. We can nickel and dime on various aspects of it, but it's the whole system that's just not meeting our workflow. And the response I got from a senior VP at Cerner was illuminating. He said, first of all, you have to understand that we're going to try and change the way in which you practice. Well, that's nonsense, because they had no idea how we practiced. The second was, they wanted us to understand that they're writing a system that goes across a whole lot of different domains, and that they can't write specific programs for every individual unit or set of circumstances. So what they're saying is they want us to practice at the median. I've never practiced at the median. I don't intend to practice at the median, and I don't want to be forced to practice at the median. So electronic health records have a very important enterprise-wide function to collect periodic data. It's the source of truth, but it's not the answer for us in critical care. We need a way in which we can pull this information for the monitors and the electronic health record so that we can smooth out our decision-making and our practice variability. Here's the other problem, and I call it the corporate challenge. Healthcare IT is just a huge portion of our budgets in institutions now, just huge. And every time you want to implement something that's new, the first response I get from the executives is, well, show us what the return on investment is. And the problem for us is that we've got all this data, and they want us to be able to interpret this data to determine what a return on investment is, which is usually some way in which to save money. All these steps to get that return on investment takes time, 2-3 years. It requires various studies, obviously, that really look at it before and after type series. So we can't have that luxury of time. We need to have this now. And for institutions to concentrate just on a return on investment that looks at financial aspects is wrong. And we need to be looking at how we believe the technology we introduce will improve the outcomes from survival, morbidity, and length of stay. I'm not dismissing the financial components. It's clearly very important. But we will always be 2-3 years behind if that is the only metric by which institutions are prepared to put money into these systems. So how do we use big data in ICU? Well, I see it as 4 ways. We first of all need to have meaningful visualization and interactions with the data. We need to be able to interact with it. We need to integrate it. We need to look at the trends, the relationships. The old flow sheet at the bedside, I love. I'd like to be able to replicate that in a monitoring device. And we need to be able to use this data to help us in our own communication, to trigger a response. I'm not talking about machine learning. I'm talking about looking at the trajectory of a patient that tells you that things are not going as you anticipated, and that it triggers a response from us at the bedside, tells us something's not quite right, brings us to the bedside, makes us aware of that. We need to capture and store this data so we can analyze it. And I mean every bit of data, capture it permanently forever. That's certainly possible. There's a lot of talk about algorithm development. Well, the problem with an algorithm is it has to be hosted somewhere. You have to be able to see the value of that algorithm. You don't need to know the mathematics behind it, but you need to... I apologize for that. And then we need to be able to share it. So let's look at data acquisition to start with. There's two types of data. There's the validated data that ends up in the electronic health record. That's sequential. It's validated because at a certain point in time, those numbers on the screen are verified by the nurse as being, yes, they reflect the patient at that point in time. Click, in they go. That's the validated periodic data. For us, it's the unvalidated data. It's all that continuous streaming data that we need to be able to collect and to store. That's the key information that we want, because then we can start to look at the frequency of that data and the changes in that data and to really do some very nice mathematical modeling on the data. We need to have a different way to represent the data that's not dependent on Philips or GE or any other company telling us how they think we like to see data. So we need to be able to integrate data streams so that we can interact with it, but we also want it to have a low footprint on healthcare IT. So being web-based is very important. And we need to be able to access it. And that means not just at the bedside, to be something that is scalable so that you can VPN from home, see that information very clearly and what's gone on over time as well. So one of the things we've been working on is called this T3, which is a tracking trajectory trigger tool. It basically takes data from the bedside through the Philips monitor, or any monitor for that matter, any other devices that we've written the drivers for. We store it, we integrate it with the hospital systems, and then we feed it back into a different web-based program that's also available at the bedside and that you can access remotely. It provides a unit view. And this area here is, I've got under a stability index, which I'll talk about, but it's really a way of looking at what's the overall acuity within the ICU. Where are the hotspots? Where do we need to put the resources, cohort patients, cohort start? That's important. And then we have a different way to view the data that I said is web-based. We can analyze trends through a drag and drop interface. If you think of Google Maps, if you think of iTunes playlist, all the things that my kids use, it's second nature they would expect us to have, which we don't have, we should be able to incorporate that. We can zoom in, zoom out. We have a customizable dashboard. We can, as I said, zoom in to really very narrow time frames that helps you really dissect out the information, and its ability to gather new information so that continuous calculations are done, like perfusion pressure, coronary cerebral perfusion pressures, rate pressure product. If the data is available and you can do the calculations, then that should be done in the stored data and fed immediately back up into the program. So it's a different way for us to interact and to integrate with the data. Importantly, you can annotate it, so you can actually capture your decisions on this particular program, and you can set the targets. Currently, targets in the ICU are set by standardized or normalized data. Unfortunately, our patients don't really fit into normalized ranges. So you can set targets that are procedure, diagnosis, and patient-specific so that you can now track patients within the range that are actually important to them and the management we're providing. So the data analysis is important to develop a way in which we have a trajectory. By that I mean, let's take the example of the Dow index. 20 stocks make up the Dow index. They're changing every second, and therefore the Dow index changes as a result of integrating those 20 stocks. We should be able to, and we can, take data streams. We determine what are the important physiologic variables that we see as important in terms of determining the course of that patient, and use that data to develop a Dow index equivalent, a stability index, a trajectory index of some sort. Now, algorithms. There are different ways in which these can be developed. They need to be predictive. That's their main aim. And there are probably two categories, to be simple about it. One is looking at the variability or the frequency variability in a particular signal, and the other is to use estimations and probability of change. So there are two ways in which data is now being analyzed. There's this, we grab the data, we have various customized networks, aggregate the data, and then it's taken offline for analysis. And that's probably the most common way in which data is analyzed right now in the ICUs. There was a recent editorial in the American Journal of Respiratory Critical Care Medicine looking at big data in the ICU. This is an adult setup, but it's based out of the MIT lab of computational physiology and the MIMIC database, where they take a large amount of information from intensive care units and they're looking at waveform analysis in particular that look at ways in which the frequency of a signal is varying and using that frequency to look at patterns. So it's pattern recognition. The value of this is that it's open source, data sharing agreements, but the idea of the MIMIC database is to allow researchers to look for those signals within all the data that we have and then to feed it back to us at the bedside. That last piece hasn't occurred yet. They've got a lot of information that many researchers are using to try and look at what is going on, what may be predictive. It's yet to come back to us in the clinical setting that's of value. So what we need to be able to do is to take, if you're taking offline data, to feed it back for real-time clinical analytics so that it then allows us to interact with the data and improve our treatment. Well, there are a couple of examples of this that are now available in critical care. One is by Andrew Seeley's group in Ottawa, that they look at the multi-organ variability analysis, and they're looking at variability in respiratory rate, heart rate variability, and so they take these particular waveforms, they look at the relationship to clinical events, such as the risk of infection or accidental or inadvertent extubation, and in particular looking at the loss of variability. We should expect variability. That's the nature of physiology. It's that loss of variability that is the signal. And so groups like Andrew's have been looking at respiratory rate, heart rate variability, and looking at the loss of variability. And they've applied that to things like extubation failure. So a patient meets extubation readiness criteria, but there's a loss of variability in that signal, and that tells you that, in fact, that patient may not be ready for extubation. So these will be available at the bedside. How they're represented at the bedside is yet to be really determined. The Artemis project and the HEROES system are both neonatal intensive care systems, once again capturing data at the bedside and looking at variability in the frequency and the patterns of that variability. And in particular applying that in the NICU to the risk for apnea, risk for infection. But once again, this data is taken offline, analysed. How it yet feeds back to us to make decisions is yet to be really determined. Our approach has been one that's different, and it's been based on this Bayesian network that really looks at what's the probability of an evolving physiologic state. And it's, I cannot go through the mathematical modelling that goes with this, but it involves taking all the physiologic inputs at the bedside, independent of the change in frequency, and looking at estimating what's the probability of an evolving event. This is not new. This is the way people forecast the weather. Oceanography, NASA, they're all using this type of modelling in various forms. Because what we're trying to do is move from signal-based monitoring to a risk-based or risk-driven monitoring in critical care. And moving to this type of system that is a prototype, but we're hoping to be able to start to implement, where you can see over various times all that data that we pull into the bedside, and behind this is all that information. But it's integrated, it's analysed, and it's telling you what's the probability at a various time point for the state of this particular patient. So it's giving us, not the diagnosis, but it's giving us what's the estimation or the probability of an evolving clinical state. So part of this meaningful analysis of information is looking at trajectory, but it's also developing these dynamic algorithms. And what we really wanted to look at, what's the rate of change of a variable from low-end target to high-end target range. It's not just the change, but what's the rate of change of the patient moving towards those boundaries that we set. We took a group of patients with hypoplastic left heart syndrome. This is the other value of this huge amount of data, is that you don't need a lot of patients because we're not collecting periodic information. You need fewer patients, but you're collecting billions of data points. So it enables you to actually use a smaller cohort of patients to actually estimate what's going on. And all we did was look at the value of a stability index to predict patients' length of stay in the ICU. This is our first inroad into trying to determine whether or not this type of analysis had any value. But we learned something else by collecting all this data, and that is that we actually didn't quite know what the ranges should be for these patients. So in these blue bars here, this is just for one signal. This is diastolic pressure after stage 1 palliation. This is where the patients actually fell out, all the data points, millions of data points for diastolic pressure. I asked the staff to tell me beforehand what are the boundaries. It's the target range and what's the boundaries at which you would really react. And consistently, we drove patients we were prepared to accept a lower boundary than what patients actually were at, so that we would allow them to have a lower diastolic pressure, lower systolic pressure and heart rate than what actually the data accumulated over time indicated. So we had to frame shift, and what we thought we knew about the patient was in fact incorrect. So that was a very important learning point for us as well. But this is the value of looking at a thing like the stability index or this trajectory, is that you can use it to estimate the potential of an endpoint. In this one, we just chose length of stay in the ICU, and it turned out that the stability index that I'm talking about actually was a pretty good discriminator between the length of stay in the ICU. So let me finish by showing a patient that I think is actually illustrative. This is a patient with sick kids. This is their, over a number of days, all their data We're not collecting waveform analysis, frequency analysis. We're collecting digital data to analyze it and model it in a probabilistic way. So this is heart rate, blood pressure, pulse oximetry, and other variables that we've calculated here on the way. This area here, the bottom panel, is what we call the stability index. This patient had a problem at this point here. You can see here that there's this period where we're not actually monitoring data, and because we lost arterial access. But let's concentrate on this area here where an event occurred. So we start to tease that out a little bit, and we've got nice pulse width, heart rate, but there's clearly something that's happened at this point in time, and this index has risen dramatically as well. And if we drill down into this further, you can see this event occurred. This was a patient after stage 1 palliation who was actually doing pretty well in the unit, was extubated on no inotrope support. In fact, we were getting ready to send to the ward. Had some residual problems, but not out of keeping with what we would expect in this population of patients. Patient needed to have 2 procedures. One was to get a peripheral IV. Had been with us for, by this stage, 3 or 4 weeks, didn't have a lot of peripheral access, had lost what access there was. So the staff at the bedside started to search for an IV. Very stressful procedure in this particular patient. Patient's crying, people trying to poke all over the place. Finished that procedure and then called for an echo before the patient went to the ward. We didn't really need the echo, but it was asked for. So echo come. Now, echoes are not benign procedures. And in this particular patient who'd already been stressed was just yet the final straw here, because the patient arrested, became bradycardic, desaturated profoundly. We actually got the circulation back initially, and then the patient continued to deteriorate. We resuscitated to ECMO within 25 minutes, and so we rescued that patient. And we were all pleased with our performance, and child seemingly stable on ECMO, came off ECMO 2 days later, and has subsequently gone to the ward and gone home. But if you look at this area here at the bottom, this is the stability index. Before this event occurred, the stability index, and the higher the index, the more unstable the patient. It's telling us that there is an evolving problem. The heart rate's going up, the pulse width is narrowing, the saturations are falling. All of those, though, were occurring at the bedside with everybody focused on the patient. There was a lot of noise, and we lost the signal. We have a signal-to-noise problem in the ICU. This patient we rescued. We had, as I said, a very low failure-to-rescue rate. Consequences on this patient, though, was neurologic injury with areas of infarction, which will have a longer-term impact on this child's quality of life. Technology can be used to make us safer by allowing us to predict what's about to occur, by allowing us to diminish that signal-to-noise problem that we have in the ICU. So we need to be able to capture, store, and share this data. We need improving visibility. We need a platform that allows us to host algorithms and to start to be really targeted and predictive in the way in which we manage patients. So technology will enhance quality and safety, but we need to move from this descriptive to predictive analyses, and it's there. It's coming, it's emerging, and it will change the way in which we practice. Data will be more visible, more integrated, and actionable. Thanks for your time.